where this discussion came from was the Early Care and Learning Partnership when we started out a couple of years ago trying to look at the way healthcare and early care and learning could be connected, and particularly could the health world help families to pay for early care and learning services if their physician felt that that would be valuable for them. Um, it's been a wandering path. We were initially told, no, it can't happen, but it seems as if we're getting closer and closer to people recognizing that what happens in those early years of life from pregnancy until about age 3 have a critical impact on long-term health and chronic care. And there's more and more research about the importance. So, hey, Ellen, we came up this small group, and we don't have any staff. We're just a little nonprofit with sort of 4 things that would make a huge difference in our community, that being the primary one, that the healthcare world and the early care and learning world would be closely connected, and physicians could prescribe early care and learning services, high quality ones, for their patients. The second one was we were realizing that there's still a huge number of people without healthcare, and that healthcare was still for many people connected with their employers. So advocating for universal access to healthcare that was not employer linked. We've been talking about preschool parity, which meant that for all families of 3 to 5-year-olds, they would be receiving free preschool services on the same, if they wanted them, same hours and days as their older children receive regular public educational services. And then the final one was really looking at our small communities, and particularly the schools that were sort of on the chopping block for being closed, and saying, is there a way that we could better utilize and support these schools so that they perhaps included community wellness services, services for elders and childcare, as well as elementary education. So that's where we came from. We realized as we've been delving into this number 1, universal health care for everyone, that there are incredible challenges in the healthcare system. And I know that everybody who's on this call knows what they are, that people don't have healthcare. Many of the people that do can't afford what they've got, that instead of the funding primarily going to the people that provide direct hands-on healthcare, whether it's mental health services or dental or home-based care or physical services, many of the dollars flow not just to the top of the hospital systems, but even out of the state and into people that are buying up these managed care systems. So there are a lot of concerns about the way the money flows in the healthcare world, as well as, do we have the capacities we need? And our healthcare systems, our mental health, physical health, dental, vision, home health services appropriately connected so that they're serving whole people, not just little parts of our bodies. So, I hope that's enough background. We want to thank Christy and Jessica, who have been on these calls before. And what we found, we will send you all a summary of the first round of discussions, but we thought the most useful thing would be to ask each of you who was not part of the first discussions to share your perspective, ideas. We're really focusing on what could make a positive change. You're welcome to talk about what the problems are, but I think we mostly are saying, is there a way that we can move forward here and have things be different? And we also wanted to acknowledge that these discussions are going on at multiple tables now, right away. So I see Linda's nodding her head. So Linda, when you speak, maybe you'll talk about the table and what you're doing. And Ellen's been working on this issue forever. So all of you have channels into making a difference. So other questions before? This is very informal. We'll tell you what we'll do with it. We will summarize the calls and we'll share it with everybody. And hey, Madison, maybe we'll start with you. And we have to tell you that Darla's got a new puppy. So if she disappears for a moment, it may be that she's taking care of her puppy. So let's open the floor. Let's start with you, Linda, just to introduce yourself and talk about what you're working on. And it doesn't have to be what you're personally working on, but your thoughts also about how we could make a difference.
Okay. I'm so glad you're doing this. First of all, I'm the town chair of the Bristol Democratic Committee. But probably more important is that I'm a retired nurse practitioner in women's health care, and was very upset when Planned Parenthood closed, and made myself vocal and let my legislators know, et cetera. And since then, I've been getting more and more into healthcare and the problems. And I must say that Ellen Oxfeld has been my mentor on a lot of this, because I've worked overseas for 28 years, and I've been back the last 5 years, and I'm mortified what's happening here, because it is my home. So we're going to have and you're all welcome to, we're going to have a healthcare forum on the 10th of November. What we're trying to do is let the community know that we think the first step to try to solve some of these problems is to have a universal primary health care. Start there, and then maybe we can build on it. We're going to have Deb Richter's going to talk about her frustration about people won't come in for primary health care. They don't come in because they have such a high deductible. They don't want to pay for the primary health care. And so people aren't going. So high blood pressure, diabetes, all these things which need to be followed, they have to pay for. So even if they may be uninsured, but they may have such a high deductible, they don't go in. So it looks like Vermont could afford to provide everybody with primary health care. Deb Richter also feels that if we go that way, we'll get more primary health care physicians staying. I'm hoping that more nurse practitioners will come in. I feel that we have a real role in primary health care in Vermont. I'm so sorry we lost Rachel Guy, and those at Planned Parenthood. So, and I did a little research on the lack of providers. I looked at all the primary healthcare providers in Addison County, and the soonest a new patient can go in for primary care is in Brandon, and there's a 1 to 2 month waiting list. Mountain Health has an 18-month waiting list, and the others have 6 months waiting list to get in for primary health care as a new provider. So we're hoping that if we can go with the University of Primary Health Care, it pays for everybody, pays them correctly. We can do that, that it will bring in and keep primary health care physicians. So that's what Deb will talk about. Mike Fisher's coming. He's going to talk about the issues of medical debt. I have 2 people that are giving their personal stories. And Chris Bray says that he will introduce in the legislature this session to go this way for universal primary health care. But we got to get people behind us. And we just need we need to let the public know that this is at least a first step. We can't do the whole primary health care forever for everybody. And if you say Dr. Dinosaur, people get Dr. Dinosaur, so it's Dr. Dinosaur's under Medicaid, but this is for everybody, but they sort of understand the Dr. Dinosaur model. Maybe we should call it the Troyanus, some other kind of dinosaur for all of us. But so that's where I am. And I have one other issue. I'm very upset with Medicare Advantage, taking people into Medicare Advantage. It is absolutely a scam. It's terrible. Every day I get something about joining Medicare Advantage. I talked to Peter Welch yesterday. He was in Virginia. I said, what do you think about this? He says, it's terrible. We must address it. I don't understand why UVM Medical Center has their own MVP in doing Medicare Advantage. So I've written several articles in Front Point Forum and in Addy Indy. So I've got 2 big issues. So I'm very passionate about both. So there you have it.
Well, we're so happy you're here, Linda. And one of the things that we've been compiling, Catherine Torres, who's part of the group that's been looking at this, has been putting together files of all of these, of letters and research studies and things like that. So if you felt comfortable with having those shared again and again with a wider public, we would really appreciate you having us um, keep that in the file so people could access it easily.
to for me to send you the things that I've
Yeah,
written.
if you would send some of the things that you've done, and I've read some of your things on Front Porch Forum too.
Okay, well, I'm sorry, I've never met you before. So when I saw your last article in the India, I went, oh.
Well,
So-
I think that's one of the astonishing things for many of us, and I think COVID certainly exacerbated it, that many of us have dreams about changing things, but we don't know each other, and we haven't really been together that much recently.
I
So
wonder, I could end with one thing. I
Yeah.
have on my mirror, I read it every morning. It says, if you don't speak up, you're not heard. So there.
Nice sticker. Yeah.
Linda, can I just ask you a question? Are you available to answer questions just on about the Medicare Advantage issues? And if so, do you want to leave your contact information in the chat or something like that?
I'm referring to people to Age Well. They have free consultants there. And the head or one of the leads of SHIP, Ellen can probably tell you, it's called SHIP, but it's under Age Well. They put on a whole thing with Marvin Malik from one of the hospitals, and they talked about medical advantage, and she was on it, and she said, call us. And after that VPR noon edition with SHIP and this physician, their phones were going off the hook. So people don't know of this great resource. So that's who I would refer to, but I'm certainly willing to talk anytime, but I'm not Ellen probably knows more than I do, but I'm learning. This is complex, but I'm willing to talk anytime. Yes.
Thanks. So maybe we should shift over to you, Ellen, to introduce yourself.
Hi, yeah, I am Ellen Axfeld, and also I have to apologize. I'm doing shifting Zooms today, and I'm on a search committee for a department up here in Middlebury College, and our meeting starts at 5. So that's why I'm sort of butting in, and I feel bad, but the rest of this meeting will be recorded, right? So I'll be able to catch up. I wanted to just add a little bit to what Linda had to say. And I think one way to think about this is these sort of levels of activity, right? So the level that Linda and I are focused on is the legislative level, right? That's not to mean that it's not a worthy or not a completely worthy effort to try to get grant funding, for instance, to do something right here in Addison County. What we are, and that's great, that's fantastic. What we are focused on is getting changes at the legislative level, at the state level. Why the state? Because, you know, I don't know if you've looked at DC lately, but, you know, we don't have very high hopes for Washington, D.C. But we did pass a bill in 2011, Act 48. That bill has never been rescinded. And what it said was that Vermont needs to move to a publicly financed universal system. Why publicly financed and why universal? Because the problem isn't really that my healthcare is good and yours is not so good. It's that we don't pool it all in one pool. So, you know, if you put all the Medicaid people in one pool, well, then you're not getting the money from the people like me, right? So plus 1 out of every $3 in our current system goes to admin costs because we have so many different plans and all that administrative waste. So that was Vermont's roadmap in 2011. And we know we didn't get there. And, you know, Governor Shumlin I like to say he pressed the pause button. So then people sort of regrouped and said, well, if we can't do it all at once, how can we do this in stages? And why start with primary care and why have everyone in? Everyone has to be in. If you don't have everybody in from the get-go, you have the same problem that you have a program for the poor, programs for poor people or poor programs. You don't have the, you know, putting everything in one bucket and you have all the excess admin costs. But starting with primary care is really, really important because A, it's the point of entry, as we know. That's where people first encounter somebody and their first problems are diagnosed or found or taken care of. It's the one sector of care that's been shown to actually improve overall population health. That is, if you have a primary care sector that's accessible to all, you can actually improve your overall population health. And it's very, very cheap. So primary care is 6% of our total healthcare costs. We spend 6.5 billion in Vermont every year, every single year. But primary care is only 6% of that. And we had back in 2015, the Shumlin administration did a study on, what would this cost to finance? And we've had bills for universal primary care every single year in our state legislature, sometimes on the House and Senate side, and sometimes just on the House side. Last time, there were 44 co-sponsors of a bill. Claire Eyre, who many of you may know, was a very wonderful proponent of universal primary care. And she got a bill right through her committee when she was Senate Health and Welfare Chair. And then there was all kinds of shenanigans. I won't go through it, that it didn't go further. But we think, maybe the time is ripe now, because it's so effective. It will do so much. The stories of people, and you can hear some of them on November 10th. I'm sure, Jody, you know plenty of these stories. People don't come in because they have a $50 out of pocket or $100 out of pocket. By the time they come in, they have, stage 4 cancer, right? You could resolve this with a publicly financed universal primary care system, where primary care is just a public good, like our roads, like our bridges, like our public schools, and it's cheap. Fortunately, Chris Bray is very, very interested in it, and we're very happy about that on the Senate side. And I know Brian Sheena, who's from Burlington, actually Dave Sharp was a big co-sponsor of universal primary care from Bristol when he was in the legislature, but I know there will be a bill in the House. But the thing is to build up public support for this so that our legislative leaders don't sideline it. I think what's kind of happened is, these bills have come up, they're so worthwhile. And yet, the leadership in the House and the Senate says, there's other things we can do. So we need, I think the time is ripe. That the crisis in healthcare is getting worse and worse. And I really feel like, I don't, Christy's my colleague up in Middlebury, and, I don't think about it when I've got a $50 copay. Of course, I don't think about it because I've got a very nice job here at Middlebury College, but most people do think about that, and then they don't come in. And also, the other problem is by not pooling our resources, we're wasting all that money in admin costs. So that's the basic, the simple idea of universal primary care is to start with a universal public good, and hey, if it goes well, then add hospital care, then add, specialists, etc. But you've got to start somewhere. So that's kind of it. And oh God, I feel really awful because I'm doing I'm on this search committee. Christy knows about it.
Ellen, you're so articulate. It was great to hear you talk. We're going to look forward to maybe having something shared. I admire Deb Richter so much, and she and Con Hogan and I were working on this when he died, and it just, I think there's, the other thing that we talk about is, could we have EPSDT, which we do have for everybody, and it would include all kids, and it would include all the things that children need. So yeah, thanks for being here.
Thank you.
You'll get the notes.
Yeah, and will we, just one real quick thing, I think, Linda, will we be also recording the November 10th meeting?
Yes.
Okay, so if any of you missed that.
And Middlebury TV too.
Great, okay, that's fantastic. Okay, sorry, I'm just doing these, what is it, alternating Zoom.
We're glad you were here.
Take care, bye-bye.
Thanks. So Bethany, I think you're the next person on our screen.
Sure, I'm not sure what to share, so I'm new to the group, and came based on the conversations that had happened back in October that I wasn't able to attend, and saw those takeaway points and was really intrigued by conversations around rekindling relationships and communication. So hello, Cheryl, a few of you know who I am. So I'm Bethany Yon. I work at the health department. I'm in the Office of Local Health. I'm covering both Addison and Rutland counties. And my body of work is around chronic disease prevention. And you've seen my cat going back and forth because they're incredibly needy. I was gone all day, but I was up in Killington, actually at a rural health conference. The New England Rural Health Association had their annual meeting in Killington yesterday and today. And so just so you know, lots of really intriguing conversations about using community health workers, building that force in the state, and really lovely models of what school health looks like in rural settings. So just some really, really exciting ideas and thoughts. And there was a good team from Addison County there, from both Porter, the health department, SASH. So yeah, we were well represented, which was lovely. So there'll be some more conversations to come. I think I can share, we do have some new old data. For those of you who know how our data sets work, they're collected and they go to the federal government, who then works with them, and then they send them back. And then with COVID, there were so many delays. But we do have our new, it's new for us now, 2019-2020 behavioral risk factor surveillance system data. And that talks about a lot of different things. This is an adult data set, so pardon my eyeballs as I just pull it up for a piece and I can send folks the link. But I just wanted to share from that data when we're talking about primary care and concerns about cost. Well, obviously we want numbers to be 100% that all adults have a primary health care provider. Addison County, from breakfast data, 86% of adults in Addison County are reporting having a primary health care provider. And in terms of adults who didn't visit a doctor because of cost, it's 8%, which is pretty much the same as the rest of the state. So I can drop a link to that report into the chat. Again, it's not today's data, and we know that the pandemic really has made things much worse, and it will be interesting to see what data looks like once we have the next round of it. But I just wanted to share that out. But as always, when I look at these numbers and say, oh, we're the same as the state, it's still not 100% or still not zero, which is really where it should be, that everybody should have primary care and nobody should be delaying or not going to a doctor because of costs. So I just, share that perspective. But yeah, I guess I'll leave it at that. And if folks have questions, but I will drop a link to that data set in the chat, and literally, I think it's hot off the press. It's within the last less than 2 weeks. So it's brand new for us. We're all still putting our fingers into that data to get a sense. And right now it's just broken down at the, we have county level comparisons. Overall for the state, different demographics are compared. So men versus women, age, socioeconomic status, equity issues. I'm hoping that the data team up in Burlington is actually going to be looking at that data to break it down, so we have that level of detail at the county level. They just haven't gotten that far yet, but they usually do that, since that's really important information for us in the state, especially as we're doing a lot of health equity work right now. Questions, comments, thoughts based on that little rambling?
Well, a quick comment was, and then Linda has a question, was, the issue of data, and do we actually know what's happening in our county, and could it both be timely, linked with stories, and county base came up. So I'm really delighted that you talked about it. And there's nobody here from United Way today, but that was another big issue, and I think they're spending some time on it. But
yeah, and what they're looking to do to get timely data will be youth-related data, so still very relevant. But the project that they're embarking on now, the Planet Youth Iceland Prevention Model, which has been going on around the state for a number of years, so we have some lovely information about how that project has worked in other parts of the state, and that is a timely turnaround for data. So the communities that have been a part of that model for at least 3, if not 4 years now, are collecting data now. And then that data turns around within like 6 months. So really quick for it to turn around so that you have, you know, as best as you can consider real-time data. And that's youth and looking at markers of mental health, stress, substance use, resiliency.
Thanks. Linda, you had a question for Bethany before we?
This is great. This is great information, and it sounds much more optimistic than I presented in terms of, well, I was looking at new patients, but you said that 8% of people weren't able to go couldn't afford to go to primary health care, but
What it says is that this is 8% of adults delay medical care due to cost. So so they're not visiting a doctor because of cost. So that's the specific, that's the official question that's asked, which is always how we have to sort of frame these things. That's the best we can do with it, just based on the questions that are asked. But thank you.
That's amazing that it's that low, because because the ERs are just like an urgent care, they're just booming. They're just over, and they say this because people aren't going for primary care. They can't get into primary health care. And so our ERs are over. So things aren't making sense to me, but.
Right. And I think that sometimes, or Jody, maybe you can speak to that, because I think that has to do with oftentimes the timing. So when folks need a visit, they can't get to it because it may be weekends or evenings. And there are, depending on how many urgent care facilities and what their hours are, that becomes the access issue. And I know in other parts of the state, they've really been, Rutland County specifically, since I cover both counties, has really worked on a, sort of like a form or a flow chart. Where do I go and when? Trying to get a message out to the general population for, depending on what's happening, where should you go, to try and take some pressure off of the ERs that are getting overwhelmed with folks that could indeed wait until they see their primary care or call and such. So I wouldn't be surprised if that's part of what we're dealing with, as well as people just don't know where to go.
So do you think, do we need a universal primary health care? What you're saying is we don't really need that with this 8% is 8%.
It's still 8%. I mean, that should be 0.
Yeah.
Bethany,
Yeah.
I don't have the answer, but I'm asking a little bit of what Christy Bright is asking also is, well, what about the invisible folks that did not respond to this, the people who don't have internet, who don't have, you know, the ability to answer your survey, who don't want to answer the survey for other reasons. And so
right. So the survey
does seem pretty low.
It does. And yes. And so when I send you that report, all of the modeling and how that works is going to be there. So you can see that. It is a phone-based survey. It is not an internet-based survey. And Jessica, do you remember, are they doing cell phones now? I mean, I know all of the other big federal studies are using cell phones.
I'm not really sure, but I will know. But it does list out, just like you're saying, in the front of that survey, it does talk about how they do it and how the information is collected, and it gives you the sampling and all of those pieces, so you understand where the data came from and who they collected it from and what that looks like.
But certainly there are going to be folks who are. There are clearly going to be folks who are missing. We know that. So yes, so perhaps that 8% is underrepresentative. So, but I just wanted to, but it's the best data that we have. And because this particular data set is one that has been collected for many years, it's a way to look at overall trends over time. So that's the other way to really look at it, to see, have there been drastic changes over time, or are we seeing, is this the same thing, in which case we know that there are issues, and so what can we do to address those issues? Great questions.
Yeah. So I'm thinking there are a couple of people that you maybe haven't all heard from or don't know. Maybe Natalie Peters is on. Natalie, do you want to introduce yourself? We're not seeing you, but I hope we're hearing you.
Thanks.
So I'm not, and Madison, I'm not sure, I'm not seeing Natalie. I'll send her I'm seeing a box with her name in it, but I'm not hearing her. And Madison, maybe you could talk about what you're doing. I don't think people met you last time.
Sure. Yeah, I'm sorry, my camera's off. I have a cold, so I can't spare you from my croaky voice, but I will spare you from my bright red nose. Yeah, so I don't have too much to report. I think the best I can be doing is listening to what all concerns you have. But I am the energy planner at Addison County Regional Planning Commission. I am also the staff person in our office working on a health equity grant right now. And this is a space that our office doesn't get to work in very often. And so I'm taking advantage and attending a bunch of meetings like this to hear what's going on in health and wellness and equity. And so really I'm trying to collect some information and get really great sources of data like what you're sharing now. We talked a little bit in October about Addison County is working on rewriting our child care section of the regional plan. And so I'm sure we will be reaching back out for valuable data and input from you all as we kind of launch that process in the next year. But I think those are the highlights. Our health equity project is aimed at municipalities and how they can integrate health and equity into their town planning processes, into kind of the progression of grants that they pursue, the considerations that they use to evaluate projects against each other, those kinds of things. We should have a toolkit for you to take a look at from across the state in a couple months. But other than that, I'm just happy to listen in. So thank you.
Well, we hope you recover quickly. And
Thank you.
Jessica, I'm not sure that everybody's met you as well.
Sure. Hi, everyone. I'm Jessica Hillier. I'm the prevention consultant for the Vermont Department of Health. I started about 8 months ago, and I'm also here in the same kind of idea that that Madison just said, is to kind of to listen in. I'm trying to think about ways to build prevention in our community, and I think prevention and health kind of go hand in hand. When, thinking about like holistic ways to look at how everything is happening in our community. And so I'm also here just to hear what's happening, and again just to thinking about resources and ways to connect everyone. I think in the notes that was the thing that kind of drew me in, was thinking about how to reconnect and how to move forward in our community and what that might look like.
Love it. Thanks. I'm glad you're here again. And Christy, thank you for coming again. Do you want to share with people who might not know you or didn't hear you before?
Sure. Hi, everyone. My name is Christy Bright, and I'm a medical anthropologist at Middlebury College. I'm from Addison County originally, so some of you might know my parents, Mary Lou and Graham Bright. And Cheryl was my first employer at the Parent Child Center in 1987. When I was a early child educator, or I guess in those days, we mostly said child care provider. And that really got me started in thinking about rural health equity issues. My entire career has been mostly focused on international healthcare systems analysis, mostly in cancer. But more recently, we've received a grant from the state. Thank you for those of you who are here from the state, to build a school-based health center at Mount Abe. So I've been collaborating with Wanda Bouvier at Mount Abe and some folks at Mountain Health Center. And that's been great. And I'm really glad to be here because I just told my medical anthropology class yesterday that I'm on a listening tour with all my elders and all the mentors on this call who I've known for so many years, including my neighbor, Natalie Peters, and Dr. Brakeley, of course. And so it's really great to come back and be involved in all of these local initiatives. And from my perspective, I think, just a second, what Linda was saying, her two main passions, my main passions would be health equity for K through 12, I think mostly middle and high school student mental health right now, and then universal primary care. And the resources I bring to the group, maybe I'll just put those out there, would be our lab now has 22 people. These are all students who are very passionate and eager to collaborate and provide provide their help in a volunteer fashion. So you know, I have students who are trained in mixed method, in data collection, data analysis, and then also helping to design materials like these kinds of brochures and pamphlets. We've got a lot of sort of design expertise, and we do sort of ethnographically informed design, so that might be useful in terms of media and marketing. And of course, you know, healthcare systems analysis. So it's really great to see all of you and be in collaboration.
It was so thrilling when we found out that you were here, Christy. Thank you. And I'm wondering, Darla, do you have things that you want to, you're always taking care of the rest of us by doing the logistics, but ideas that you'd like to share or put out?
I think, thank you, Cheryl. I think the thing that has come to mind today as we talk about all of this is something that I heard at the Hunger Council the other day. I was forgetting which meeting I was in, that the Hunger Council was talking about, one of the women there was talking about how there's the need for, you know, for food staples is rising at a rate that we haven't seen before. And it's not people who aren't working. It's not people who are experiencing poverty the way that we are used to seeing it. It's both parents working and still can't make ends meet. I feel like we're in a place in our communities that we have never been in before. Like, we've always talked about the working poor, and it's, I think we have to expand that definition in our minds of what that looks like today, because it is 2-income families, and they just can't, you know, pay the heat and pay the food and get their kids to school and do all those things. It's just not, it's not working. So, but those families are sometimes not getting the things that they can get, like talking about from the Hunger Council, because they think they're taking it away from someone else. So, you know, that's one of the things we talked about at that meeting a lot, was how do we let people know that the more people that we can show need these resources, that the more resources we can bring to the community, and then we raise everybody up. So, I mean, we didn't come to the magic answer of that question, but I think it's something as a community we need to talk about in a really big way, and thinking, you know, reframing the way we think about poverty. It's not the way, I keep thinking of all of these horrible political ads that are happening right now, and they're talking like those people, and, you know, just the divisiveness of it. It's not, you know, it's your neighbor. You may not understand the situation that's happening with your neighbor, with their house and their 2 cars and their, you know, 2.3 kids and a dog and a cat and all of those things. It's they're struggling. Like, our neighbors are struggling in a real way. And, you know, and that just leads to so many other pieces of the, you know, mental health and physical health and all of those things. So that $50 copay may not feel like a lot when it's people that are in a very different monetary situation, making that decision, saying like $50 isn't a lot of money. It's perspective. And I think we need to find a way to change perspective. And I'm not, maybe that's what this group can do. Maybe that's what this, you know, maybe that's what, you know, these conversations can fan out and find a way to help our neighbors in a way that we haven't before. And I keep thinking of the school lunch program. I've used that example before, and how great it was when all of those barriers were gone and all of the kids could eat, and it wasn't a special ticket or, you know, I was talking about that with a friend of mine, and he said, you know, I grew up, you know, having the special ticket, or it used to be an envelope. And he said, you know, our lunch lady used to take that envelope and just crumple it up and throw it in the trash when I went through the line. And everybody knew I was that kid that got the free lunch. And that's, you know, this is a man who's in his 60s now, and that has stayed with him. So you think about carrying something as simple as that with you. What are these other, you know, how do all of these pieces come together? And, you know, our families aren't as healthy in many ways as they need to be. So how do we help them? Those are from all of the tables that that's the conversation that's happening. That's the information I'm taking away right now.
I love it. I love the whole push towards universal, we take care of each other is just thrilling to me. I remember when WIC first came out and people were saying, I can't do it because I'd be taking something away. And that campaign that the health department did to say, if you use it because you need it, it will be there in the future for other people who need it. And
So
anyway,
Linda,
Jody, we should have you also share ideas and thoughts here while you're busily taking notes. And you're still a little muted.
Sorry, I have my
Okay.
my notes on over it. I'm delighted to hear that Christy has a powerful workforce for us to tap into. That's always pretty exciting. And Cheryl and I have been around long enough to know how valuable the college can be. And so that will be really fun. And Christy, you can be sure that we're going to find some great things to work on. And so Bethany, thanks for sharing the link. I'll put that in the notes. And Linda, it's nice to get to meet you. So I'm not going to say anything. I will do this. I've been, for Cheryl especially, maybe for everybody, I've been preparing a little talk for the psychology department next weekend. And as such, I've been able to review lots and lots of stuff that I've read in the past and read a bunch of new stuff. And so when a few years ago, when Cheryl came and said, you know, we think we should be able to ask Medicaid to give us a code so that high quality early care and learning opportunities can be available to everybody and they can be paid by the medical system. And our Medicaid and Medicare people said, you know, there's not enough research on that. There is so much of that. And I just think, Cheryl, that we should take some of that and go back and say, I don't think you can say that anymore. I don't know how they could say it then, but there certainly is ample research to say getting the right start makes all the difference. And that's where primary care comes into play. Bethany, I didn't hear many years, maybe in the 90s, we did a community health assessment here with the help of David Napier, who was just recently back for a cameo visit. And we canvassed the people of Middlebury to find out who did have primary care for their children. And it was almost 100%. What I don't know, what I don't know then, and I don't know now, is are there people who are not using primary care in the pediatric age group because of high deductibles? And Linda, I don't know, do you know that?
Well, I know the high deductibles are a real issue for people who have private health insurance. But haven't done a survey, but you ask anybody about their high deductible and how it's affecting them. And my neighbor went, he had a high deductible and he went for the urgent care because he couldn't find a primary care and came out with $1,000 bill, which he said, that's, and the average person's deductible is $4,000. It can go up to $10,000. I mean, that's a lot for people, like for what Darla was saying, $50 is a lot to them. Okay, I've got Medicare, I'm on a supplement, I am fine. But I feel so sorry for people with these high deductibles, and they're really, my neighbors are having trouble. I mean, it's just,
We don't know about the children, Bethany, is that right now? I mean, we will maybe when we look at this information. Or is it going to be all adult information?
That the breakfast is just adult information. So YRBS, the Youth Risk Behavior Surveillance Data. Jessica, when are they starting? Isn't it this year that they're going to do another round of collection?
Yeah, so it's off a little because of COVID. So they did do it, and it usually happens in the spring. And then because of COVID last October, they did it, and we're still waiting for that information to come out. And then they'll do it again. My understanding is, I'm not sure if it's this spring or next spring. I'd have to look to see, but they'll do it it's every 2 years, I believe, right? And they, it's 6th grade through 12th grade. So it's going to capture like the middle school to the high school.
But I don't think they're asking about healthcare in that. That's really more behavioral, risk resilience, behavior based.
Darla, what about you? Do you know in any of the entities that you belong to, do they know about who now identifies as having a primary care pediatric home, a medical home, who uses it and who doesn't use it because of a high deductible or some other possibly remedial reason?
Yeah, I don't know the answer to that off the top of my head, Jody, but I'll reach out to our data and policy director. She may have that information. We also just concluded the family needs survey. It's about folks who are accessing services and what their experience was been, but that data may be somewhat telling, along those lines as well. So that just closed on Friday or Monday, actually. So when we get that back, I will share it with this group for sure.
Yep. Thank you.
I think Dr. Dinosaur has really helped a lot for the peds. That's been an amazing
It's been
program.
huge.
Yeah.
And I think the increase through the state child health improvement program also, and the linking of eligibility between WIC and children's health care. I feel like we have lots of things that we could learn from. One of the questions, first we should ask you, Natalie, are you there and do you want to share something? I'll reach out to Natalie on email afterwards, but we have 4 minutes left. I think what we've all been hearing is these discussions are going on in so many places. Is there, Darla and I were talking about, can we look to United Way to sort of keep the big picture for us and the rest of us can work on specific projects? Or what are your thoughts about how we stay connected, how we move our thinking forward together?
I'm definitely coming to the November 10th meeting. Thank you for organizing that. Trying to get some other people to come. I love the idea of like even a once monthly check-in. I love hearing updates from people. One of the things that just occurred to me, because I was also very interested in the 8%, because I know anecdotally of some people who don't qualify for Medicaid, who are self-employed and don't like the government. They don't like the state. They don't want to talk to the state. They won't pick up the phone and talk to the state. So I'm thinking both of this group that has this like mistrust or sort of deep skepticism, not just of healthcare and providing healthcare for their kid, like this one person who I talked to whose child has not seen a primary care person or a pediatrician since the child was 2 and the child is now 5. And, it's interesting to me that this is a lot of it's motivated by their faith practices, as well as like sort of a deep mistrust in state. So I'm very interested in this as an anthropologist, actually, and hoping to sort of take that on as a project. But I just wanted to put that out there because I think it does possibly answer some of why that 8% is there. Maybe we could dig a little bit deeper into that because I do believe it is higher.
Love it. And I should say that Jody and I have been part of a group of people that are looking at the state level at some of these issues around healthcare. And I think that's where I first learned about the mild disaster of the Medicare Advantage plans. So we could open that group up, just to encourage all of you who are interested in staying in touch. We usually meet Wednesday afternoons at 2:30. So I'll send the link, and if you'd like to be part of that group, we'd be thrilled. Madison, you asked who at United Way is the data person. I thought it was Jessie Brooks, but maybe yeah. Okay, Bethany is putting her, and so is Jessica. So We'll send everybody's email. Darla was kind enough to collect it from all of you. And thank you for taking the time to be with us. Lots of ideas. I hope we'll have amazing change this year. We'll see how it goes. Be well.
So lovely to meet you and see so many fun, wonderful faces again. Really, really.